it a good idea if you have a headache, maybe take Tylenol one day, take Advil another day? Is it a good, does it make a difference?
Doesn't make any difference,
Doesn't really
no.
matter.
It can sometimes, if you take Tylenol the first dose, Advil the second dose, it will extend, they'll both last longer. You get a longer effect out of them, it doesn't,
I
no.
thought you could mix the two.
You can mix it too. Yeah, we have products
Yeah,
that have the
that's why
two
you
together.
alternate 'em when
Yeah,
you have
you alternate them.
Vicodin.
Yeah.
Well, that I know, but I
Right.
thought someone said you can't mix Advil and Tylenol.
No, you can, and they work differently, and I'll tell you that in just a sec. The other thing with the Tylenols is that they're, like you've said before, there are a lot of products that contain Tylenol that we don't think about. Vicodin 500 has 500 milligrams of Tylenol in it. We used to have Darvocet N100, that had 650 milligrams, that's off the market now. But so there's a lot of things that we need to warn people about. There was a study in an emergency room where they looked at 118 people who were given Tylenol-containing drugs like Vicodin when they left the emergency room. How many of those 118 do you think were warned about the Tylenol in there?
One.
Zero. Nope, zero.
Zero.
I don't
Okay?
think I was ever warned.
Yeah, you never will be, okay? But you gotta know that if you're taking a lot of Tylenol, you gotta be careful, okay? Now Tylenol works again for pain and for fever, okay? The next class of drugs, the anti-inflammatories, which is the Advil and the Naprosyn, the Aleve,
Can't take any.
those drugs take down inflammation or swelling. So if you're using a drug like this, okay, to treat arthritis, it's the right drug to use, okay? Because arthritis is caused by inflammation within the joints, less cartilage, so you get inflammation and swelling in the joint, okay? Tylenol does not help with inflammation, okay? It helps with the pain, but it doesn't help with the swelling and the inflammation.
Is that why they have like a Tylenol arthritis that has like Naprosyn in it?
They do that, but Tylenol arthritis is almost a misnomer. Even though it's really the first line of treatment for the pain of arthritis, it doesn't help with the root cause of the inflammation, so you gotta be careful. And like you've learned, all of those anti-inflammatory drugs you need to take with food in your stomach, okay? But, there's a big but to that, okay? The food protects the lining when you swallow the tablet. You take it with food, it doesn't hurt the lining. But here's some pharmacy. Every chemical that we have in our body does good things and it does bad things. The reason we have fever, we have pain and inflammation is because there's a chemical in our body called prostaglandin. When we get increase in prostaglandin, we get fever and all of those things. These drugs, Tylenol and the Aleves and those drugs, block prostaglandin. So your fever goes down, your swelling goes down. The good thing that prostaglandin does is it builds the stomach lining. So even if you took your Aleve every single day with food, over the course of time, if you took it for 6 months, 8 months, 10 months, you still will probably have some stomach problems. Because because it affects the lining of the stomach.
What
So you
about
gotta be aware of
aspirin? Oh, okay, that's not.
Same thing.
Okay.
Aspirin will do the same thing. Aspirin's more of a localized, but it still does the prostaglandin thing. Okay? Migraine drugs, we don't. And the other thing is, here's one other thing about the anti-inflammatory drugs, the Advils. They cause incredible ringing in the ears. I don't know if our ears all ring, but in lots of folks, you'll get increased ringing in the ears with these drugs. So just be aware that if somebody comes to you, now the ads are on TV for that, but you can get a lot of ringing in the ears from those kind of drugs. Okay. The anti-migraine drugs, those are injectables. We don't really use them. Aspirin, everybody knows what aspirin does. It takes down swelling, inflammation. Also makes the blood less clotting, so it doesn't stick together so
Sumatriptan's
much.
not an injection.
It has both.
We have
Both an
a president
injection. You
that
do
doesn't
have, and it has an
I
oral
was gonna
tablet.
say
Yeah.
almotriptan is an
Yeah.
injection.
Comes both. The next category, the opioids, those are the really potent pain relievers, morphine, oxycodone. Two things with that. Number one, they really will knock people on their cans. When you take them, they'll slow down their breathing and they'll constipate people. Okay, they just literally stop the bowel in its track. Okay, so most people that go on those for a long time need to have some sort of bowel stimulant, either bisocodyl or something like that, to make sure the bowel is still working, okay? The other thing I want to say about all of these drugs is that, and Vicodin and all of those drugs, is that when they make people loopy, the one thing that we really want to protect our folks from is falls, okay? Here's a study, and this has been proven over and over again. Anybody over 75 years old that falls and breaks a hip, 1 in 4 people will die within 2 years. Okay, there's study after study that proves that. Okay, So we really want to do everything that we can to prevent falls in our building. Now, they don't die from the broken bone, they die because they get a pneumonia in the hospital. A friend of mine, her husband fell, had a busted hip, he stroked. It's the secondary things that happen, and literally 25% of our folks won't survive a broken hip in 2 years. So everything we can do to make sure that our folks aren't falling is really, really, really important. Okay. The next category on page 6, the next two we don't even need to talk about. Let's move to the topicals. The Pregnenolone. Pregnenolone is a new drug, Lyrica, used for it's a fibromyalgia, which is it's a treatment. Okay, it works pretty well.
I'm not on
A little bit of drowsiness with it, but it's not a bad drug. The topical analgesics, y'all, they numb the area. So you've got lidocaine. Anybody on lidoderm patches? You know, you see lidoderm patches in our buildings. They work pretty well. Very, very expensive. About $350 a box. Fortunately, insurance covers most of that. It's one of those prior auth drugs. But literally, they just numb the area. You don't get the the nerves firing back, so you get relief. The other drug, capsaicin. Is anybody familiar with capsaicin? You'll see ads for it on TV. It's no, aspartame is salicylate. Capsaicin, we use it to treat what we call peripheral neuropathy, where you have, for some reason, either the top of the hands or the top of the feet is pulsating pain, throbbing pain. Lots of times in diabetics we see that. But what happens, for some reason, the nerves in that area are sending out a signal that it hurts when there's really no cause for any pain. This has to do with nerve endings and those things. So what capsaicin is ground up peppers in a cream base, and we rub it on the area, and it stops the nerves from firing. It takes a couple days for it to really work. So if you think about that, what are the side effects you're going to think about when you're rubbing pepper on your arms? It's going to sting, and it's going to, for the first probably 3 to 5 days, there'll be some intense stinging there. So that goes away. But the other thing, if you're helping your resident do that, number one, make sure you're wearing gloves, and make sure you're not doing this when you're done. Because literally, you will be screaming, okay? So just be aware of what that is. Wash your hands good after you use that particular medication, okay? The urinary analgesics, the only one you'll see is phenazopyridine. It's Pyridium, is brand name. I often wonder how we discover drugs, but Pyridium is a dye. It's literally a dye, and for some reason, when we take this dye internally, the first 3 days of a urinary tract infection, there's usually burning upon urination. For some reason, when we take this internal dye, it stops that burning. Don't ask me why. It's right. And the other thing is, you think about it, and it makes your urine glow like crazy. So now you've got your Alzheimer lady going to the bathroom going, oh my goodness, what is that? Okay? So be aware that those things can happen with that. The next several categories are all the drugs. We call them blood thinners. They don't quote unquote thin the blood. They make the blood harder to clot. Okay, and they all work a little bit different ways. The first category is heparin and enoxaparin. Those are injections. They use them lots of times for orthopedic surgery, so people don't throw clots from their legs. With the enoxaparin, brand name Lovenox, you may have heard of it or seen it. Two things with it. Number one, it bruises the area significantly. So people get shots in the stomach, and their stomach bruises like crazy, and it stings like nuts. Okay, it really stings, and for like 45 minutes, it'll sting. So people be aware that if your folks go out for orthopedic surgery and they have it, and you've got VNA or something doing that, it'll sting for a long, long time. Okay. The other categories, they really just stop our blood from clotting. Okay. The Plavix, you've seen the ad on the TV where the little blood vessels just don't stick to each other. That's how it really works. And then we've got our old friend warfarin, brand name Coumadin, obviously. And warfarin is a funky drug. Okay, it is what we call a narrow therapeutic range drug. What does that mean? For most drugs, we measure the amount in the blood, and we know that if we have between here and here, the drug's going to work. Okay, we have a wide therapeutic range, and you get it in here, it works. Above it, you get toxic. Below it, it's subtherapeutic, doesn't work. So most drugs work like that, and you're just refilling that blood level. With warfarin and levothyroxine thyroid, you have an area about like this. So what happens is with warfarin, that's why we have to test the blood so regularly. That's why we adjust our doses. You know, it's the hardest drug to dose. you get 5 milligrams Monday, Wednesday, Friday, except when the sun's out, and I mean, it's just really hard. It's really true. So what happens is they measure that INR, and the number you want is right around 2. So if you get it too much, then your blood is good, you can bleed. Too little, you get clots. So that's why we have to test it on such a regular basis, because we've got to get it right there in order for it to work. So that's why we do what we do. But it's still a pain in the butt. We hate it, especially for packets. You guys aren't packets, but trying to get that in a packet is really, get it right is really hard. So anyway, that's the blood thinners, the quote-unquote blood thinners. The next category are the anticonvulsants. We don't use these really to treat seizure that much anymore. We use it to treat two things. We use gabapentin or Neurontin to treat those neuralgias we talked about. And you'll see it, that's a funky drug, you have to dose it. You'll see it 100 milligrams 3 times per week, and then 200 will build up to a certain point. The other drug that we use is valproic acid or Depakote. We use to treat behavior. For some reason, people who are wild and have some increased behaviors, Depakote can calm them down. I don't know, I don't know why. With somebody who was seizure who had a behavior problem, it does a fairly decent job. The one side effect you'll see if you're in this business long enough is that people will walk, they'll go down the hallways sideways. Okay? So that is called abnormal pain, and that's from Depakote.
That's okay.
How helpful that statement is.
Now I
No, you have something like that, eh?
Yes.
It
It
explains
explains a lot.
into the stairs.
Yeah, explains a lot.
That's probably when she falls.
That's called abnormal gait. That's from
That's a
Depakote.
light going on.
Wow.
Yeah. So that's
How
a
long
second.
does it take on being on that? Does that happen?
Well,
Lenny?
it happens quite a bit.
Right
So
off?
it
Like as soon
happens-
as you take it, it could
sometimes.
happen, or you have
It's-
to be.
It's usually a build-up over
Really?
time, but I can tell from I teach this all the time, and somebody's face always lights up when I tell them watch out for
Should you
abnormal
be
gait.
changed off
Does
of
she
that?
need to be on
Is she awful? She fallen?
Well, yeah.
It's if she's fallen.
But I don't know
does it
because of
control
the
her
lean
behaviors?
or what is causing
Well,
it.
she
We don't know.
runs too. It's not
How
like she
does it
leans.
help her? You have to do a total evaluation.
Yeah.
Okay. So what is the benefit of the drug worth the risk? I mean,
Huh.
Well, yeah.
Make sure she help her so she doesn't fall.
Backs.
Really, but that's what you're seeing.
At least we know we can't go up on that.
Okay? Okay, there you go. Okay. The next category of drugs are the anti-dementia drugs on the top of category 7. I'm going to go to the board a little bit so you can get a feel. I want to talk first about Alzheimer's a little bit because there's lots of studies that show the number of patients of Alzheimer's is going to skyrocket, and it already is starting to. 50% of people over 80 will show signs of Alzheimer's, okay, whether it's true Alzheimer's or not. But dementias are really what we treat. I mean, we really are treating dementia in a lot of our folks. So let's talk about the drugs that treat Alzheimer's and treat behaviors and depression and all that. We'll talk about them all together. They're not all together in the book, but they kind of tie all together and help you understand everything we talk about.
I have a question.
Sure.
What can we take as being younger to prevent?
Nothing.
So we said vitamin B.
I'll tell you a funny story. It's not really funny. I give my Alzheimer's lecture. I've given it in Alzheimer's facilities to family members, and that's a hard lecture to give when you know the person sitting there, his mom's got Alzheimer's, and you put a graph up like this. Okay, Alzheimer's is a disease of memory. It's a disease of not being able to perform cognitive skills in a declining way, and it's a gradual reduction in cognitive ability based on memory. Okay, so if you look at cognitive function, the ability to put my clothes on every morning, or eat, or whatever, or know what time of day it is, and know, when the sun's going down. So if you look at cognitive function, and you look at time, okay, you'll see the typical Alzheimer's patient will look like this. It'll be a steadily declining graph until they pass away. Okay, that time from usually average from beginning diagnosis till death is 8.6 years. Okay, that's the average. Okay, so you know that. Okay, now when you asked your question, I gave this lecture and was giving it, and the guy looked at me kind of smiling. And his mother was. He said, "I have to tell you," he said, "I'm petrified I'm going to get Alzheimer's." He says, "I just within my." He says, "Is it genetic?" Well, we don't know if it's genetic or not, but anyway. He said, so I found a specialist at the Leahy Clinic, And he said, I called to make an appointment with this lady because I wanted to know if I was gonna get it. And the lady, the doctor, he said, the doctor literally called me back and said she would not give me an appointment. And I said, why? He said, she says to me, because Alzheimer's patients don't make their own appointments. Okay? So the answer to your question is, you don't really know. It's all based on symptoms. We can't tell if somebody is in fact Alzheimer's until autopsy. Okay? And there's reasons for that we'll talk about. But this function, and you gotta be really careful how you talk to folks with the disease. I mean, you really, I learned a long time ago as a wise guy type of pharmacist, I was, a couple things, I was in a facility doing consulting, and a guy who had Alzheimer's, and men get really agitated when they have Alzheimer's. So they spent their whole life being able to figure out and solve, now they just can't solve things. And so he's yakking at me, and the other thing that men get fixated on with Alzheimer's is money. They've always paid their bills, so how much do I owe you? Can I pay you? They want to do that. And so this particular day, he was on money, going on and on about not having money and this and that. And somebody came by and said, hey Arthur, you want to go play cards? And joking that I said, all right, maybe you lost your money playing cards. Worst thing I could have said, he freaked. I mean, to the point where I think they ended up giving him a Haldol to calm him down. I mean, I felt terrible for weeks after that. But you gotta be careful. I had another lady, this is more humorous, 3 hours pacing across in front of the nurse's station saying, where's my bowel movement? I need to find a bowel movement. Have you seen my bowel movement? And I thought, somebody had said to her, Marge, did you have a bowel movement this morning? She spent her whole morning trying to find it. She had no clue. So you've got to know your folks and know where they go and know what's going on with them, because it's where we live. It's really where we live. So what the drugs do, there is no drug that cures Alzheimer's. Okay, we all try to preserve quality and length of life with the medication. So when we put somebody on Aricept or Exelon or one of those Alzheimer's drugs, what we're really trying to accomplish is to make this line go like this. So can you see that? So we're trying to give them a longer period of time alive and improve their quality of life during that time. So there becomes a point where you say, when do I stop the drug? I mean, because these are, Aricept just went generic, but somebody who was taking Aricept and Namenda to treat Alzheimer's was spending about $500 a month, okay, at one point. So, go ahead. So what we do is, then you say this, and it's a very difficult decision, has to be made between caregiver and family, a caregiver and a prescriber, because if we stop it too soon, so if up here you say, I don't think that drug's doing anything. So I stop this drug, and all of a sudden I start to see this, okay? And I say, geez, maybe I should have kept him on the Aricept. So we put him back on the Aricept, which is good, but all of a sudden the line now goes like this. So we've always lost this space. So it's really hard to know when, and there's a time, believe me, you want to take people off.
Well,
but
my
it's
mother's going through this now.
Mhm.
She's early dementia.
Yeah,
And she refuses to take her Aricept because she doesn't want to, she can't get through to the side effects.
yeah, we'll talk about that in a minute.
Okay.
Let me talk about that side effects in
Okay.
a minute. So that's the key of what we try to distinguish with the meds. When do we put them on? When do we take them off? Because again, there's a cost factor associated with it, and again, you don't want to do it too soon, because then you end up with a mess. Okay. So let's talk about that's just kind of an overview of Alzheimer's.
That makes sense.
Okay. Now the other, I should have left on my lineup, but with this line, if you see this person that's doing this, okay, and all of a sudden one day they do this. If somebody's functioning normal, and all of a sudden you see just this sharp decline, that's not Alzheimer's. Okay, they've either had a stroke, or there's another dementia called Lewy body dementia, where there's protein deposits in the brain, and all of a sudden you'll see just a straight drop. Alzheimer's, remember, the definition of Alzheimer's is a gradual decline in cognitive function. So somebody all of a sudden just falls off the map and they can't do anything, then that's really, you need to have them assessed right away, because they could be throwing little clots or something's going on. Lewy body dementia, which is really a tough thing.
Yeah.
Lewy body, people will have hallucinations and they will hear things and they won't line up. So I'll be seeing something that's not there and hearing something totally different. It's just horrible. And we see that lots of times with Parkinson's disease, where that happens. So remember, if something like that happens, not Alzheimer's, okay? We're dealing with something totally different at that point. And we need to, person needs to be looked at probably as quickly as possible, okay?
And
you
quite
guys
often
are
a
really in a
UTI.
What's that?
And quite often as simple as a UTI.
Could be. Yeah,
Yeah.
it's it's funny.
Yeah.
You know, you look at, we talk about UTIs with a urinary tract infection with our older folks. They'll go delirious. I mean, you'll get delirium with us. And I had there's a psychologist who owns a building in Dover, and he says, I beg the doctors to put somebody on a Cipro when I start seeing things go on, because if I don't, I know that we're going to end up increasing their Seroquel. He says, I'm going to make a new drug, it's called Ciproquil. You know, because they go into a UTI and do that.
No,
It's funny.
why is that?
Who knows? They just
like
get a little bit
marijuana.
toxic.
The
Something
infection
happens
just gets
chemically.
into the brain, or-
Chemically, it just puts them in a fog.
Oh.
It just puts him in a fog. And my son, who's in pharmacy school, I gave him that tip. He was like, his professor couldn't believe he knew that. I mean, so he was a little bit of a hero with that little teeny tip. But that's the first thing you want to do when somebody starts. Number one is check for UTI and then get them assessed for either something else is going on. Okay.
That's what happened with Marilyn when sent
Yep.
sent it to the ER.
Now,
She was like,
now, in order to understand,
For no reason,
um,
she just went to
in
it.
order to understand these drugs, we have to talk a little bit about nerve function and nerve. And I call this a little bit of my lecture, Brain Chemistry 101. Okay. Now, don't get nervous. Okay. Pharmacists are really nerdy people. Okay. When you go to a pharmacy CE and they talk, we're going to talk about brain chemistry. We all kind of sit on the edge of our seats. We're just kind of nerdy that way. Most people just go like this. Okay. But I've tried to boil this down to help you understand why the drugs work. And the only way you can do that is to understand a little bit about brain chemistry and how nerves function and those things. So we're going to talk about nerve function and how nerves talk to each other. And that's really what our drugs that we use to treat these things do. Okay. So when we talk about nerves, okay, and we talk about Alzheimer's now, don't hold me to this drawing because it's really just a Lenny Parker. That's a pretty easy way to draw a nerve drawing. It's not exact, okay? Okay. If you look at nerves, okay, nerves meet each other in what are called, it's called a synapse, okay, the space between two nerves, and they line up together like that. If you want your nerves to talk to each other, the nerve structure needs to be smooth. And I always use this example, I used to use it, but if you think about, anybody who's alive like us, who knows what a Breck girl is? Anybody? Nobody?
I know what a Breck girl is.
Thank
Yeah,
you.
So you've got a smooth strand of hair and then
Yeah,
you've got all those little split
smooth,
ends.
no, not even split ends.
Oh.
Or for you younger folks, a Pantene model. Okay? If you think about the Pantene models that are on TV, their hair is smooth and silky and just gorgeous, okay? That's how your nerves want to be, so that they can communicate and the chemicals can flow down the stream. If you look at somebody with Alzheimer's disease on autopsy, their nerves look like Bob Marley's dreadlocks. Okay? Think about that comparison of a dreadlock versus a Pantene model. That's what you see, and that's why their nerves can't communicate. And so what happens is that there are 5 chemicals in the brain that cause communication and are responsible for different types of behavior. Okay? The first chemical is acetylcholine. The second chemical is dopamine. I'm sure you've probably heard these before. Norepinephrine, serotonin, and GABA, which is gamma-aminobutyric acid. Okay? These chemicals are what your brain shoots across to communicate. The first one, acetylcholine, is the chemical that's responsible for memory. Okay? So what happens when you and I look around, everybody looks fairly normal, but fairly normal,
Thanks, Lenny.
yeah, no problem, is that when we try to remember something, this nerve releases acetylcholine, okay, and the acetylcholine travels over to this nerve and attaches at a receptor site that matches acetylcholine. So this one, and then it does its job. It stimulates the little electrical impulse that causes memory. Okay? It's as simple as that. What then happens, our bodies are great conservators. They conserve all the chemicals that are in there. So it wants to reuse this acetylcholine. So in order to recycle the acetylcholine, it wants to get it back into here. Okay? So it releases off. Now in order to get back into here, it has to break into 2 pieces. An acetyl piece and a choline piece, okay? So then those 2 pieces go back in there, they join back together, and we just keep recycling and recycling and recycling. What happens with Alzheimer's is we don't have enough acetylcholine. So the drugs block this from being split apart. They're called cholinesterase inhibitors. That's what they say in your book. Aricept is a cholinesterase inhibitor. It keeps this together. If it stays together, it can't go back. It stays here. It keeps firing the nerve. So we get more acetylcholine in that space, so it helps our memory. Okay? That's all the drugs do. Now that would be great news if the only thing that acetylcholine was responsible for was memory, but it's not. Remember, prostaglandin causes fever, but it's good for the stomach. Okay? Acetylcholine, great for memory, but it does a bunch of other things. The major things you need to remember about acetylcholine is that it is in the eyes and it's in the bladder. And it's responsible for tears and it's responsible for urination. So when you have that urge to pee and you get that banging on your bladder, that's acetylcholine going, hey Lenny, it's time to pee. It's time to pee, that's acetylcholine. So what happens is that we give acetylcholine to our folks to build up their memory, and it does a nice job. But also, guess where else it happens? Makes them pee everywhere. Okay?
I got a lot of
That's
ideas.
exactly what happens, is that now we give them a drug to increase their memory, but it causes incontinence. Okay? Also, it works in the salivary gland. So what else happens? They drool. That's why you see those side effects from people who are on the drugs to treat, because we're building up acetylcholine. So we get, and so then what happens? Okay, it does another bunch of other things too. It helps our intestines move. It stimulates the intestines to move. So anytime that we give drugs that stop acetylcholine, we get a bunch of side effects too. So what happens is now we give them the Aricept, and all of a sudden they're incontinent. So now we say, what do? Can we lower the dose of Aricept? That's what we should do, but we never do. So we say, oh, let's give them a Detrol. Right? We give them a Detrol or an oxybutynin to control their incontinence, or Vesicare. Guess how those drugs work?
They do something else.
No, those drugs block acetylcholine.
Oh,
That's how they work.
that's not good.
So what happens is you're given one drug to build up acetylcholine in the brain, you're given the Detrol to block it at the bladder, and it's just a fight back and forth. So it's really the other thing. So here's the other thing with acetylcholine. This one you'll all know. If you ever taken a Benadryl or a clotrimazole for allergy, okay, that's an anticholinergic drug. It blocks acetylcholine. What happens to your mouth?
Oh, so it's like
Dry as a bone. Okay, that's because it's blocking acetylcholine, so you can't make saliva. Okay, that's what happens. Okay, Benadryl is one of the worst for that, and we give Benadryl all the time to help our little old ladies sleep. Okay, you don't know that, but Tylenol PM is what? Benadryl and Tylenol. Yeah, okay. Tell you a somewhat funny story. My mother knows I tell this story, so I'm not speaking out of school again. My mother's 84, and I picked her up about a year ago, take her for a physical. And the whole time in the car, her doctor's about half an hour from where she lives, she says, I'm really scared about having to pee. I gotta give a urine sample, I'm really scared. She's sipping water all the way over there. I shouldn't have gone to the bathroom this morning. I remember what's going on, and I said, Mom, what's the deal, you know? And so we get to the doctor's office, sure enough, Mom couldn't pee. And I said, you know, and so we sat, and we sat. And I'm not the most patient guy in the world, love my mother to death, but 45 minutes sitting there waiting for a pee is a bit much for even me to control my patience. And so finally the doc said, don't worry about it, you know, we'll catch it next time. So we get back in the car, I said, Mom, what do you take it? You know, I know what her meds are. You know, I follow her meds very closely. And she said, well, I took a Tylenol PM last night to help me sleep. Well, that bit of Benadryl causes her to have urinary retention. She couldn't pee. So watch that with your folks. I mean, it just does that. You get dry mouth. Benadryl is not a good drug for the elderly. Just mark it down. It's just not a good drug. Okay. So what we're doing with these drugs is building up acetylcholine. That's what we're going to do. The next drug is dopamine. Now, dopamine is responsible for two things. If you don't have enough dopamine, you have Parkinson's disease. And you all know the symptoms of Parkinson's disease: little tremors, small, steady tremors, or people they start to walk and they lose their balance, or they start and they stop. If you take somebody's arms who has Parkinson's disease and do this, it's like a ratchet. It goes, pop, 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 pop. You can just feel it clicking. That's from not having enough dopamine. So we give them carbidopa, levodopa to supplement that, and it helps with all the movements of that. If we have too much dopamine, now we've got dementia-type behaviors. We have hallucinations, we have cause of schizophrenia, we have all of those things are caused by too much dopamine. The drugs that we use to treat dementia and to treat behaviors, Seroquel, Risperdal, Zyprexa, all those type of Abilify, those drugs, those all block dopamine. We've got too much dopamine, we hallucinate, okay? We see things and we have behaviors and violence and those kinds of things. Now let's tell the story that we don't always have to give somebody medication. If one of your residents just happens to be sitting in her room every morning having a conversation with her husband who's been dead for 20 years, you don't have to put him on a drug, okay? If you can say, Mary, it's time for breakfast, and off she goes to the dining room and she's fine, who cares? That conversation might be pretty therapeutic, okay? But if you go to say, Mary, it's time for breakfast, and she cold cocks you, okay, you may want to think about treating that, because that's not good for her either. But you don't always reach for a drug, okay? So what happens is we give them these drugs to treat their dementia and their behaviors associated with those dementias, and there seems to be a balance between dopamine and acetylcholine. When they're in balance, and everybody here looks pretty balanced to me, is that you have normal function, you don't have hallucinations, you don't have all of those things. But what happens is now, all of a sudden we get too much dopamine, and we start having hallucinations and violence and those kinds of things. And so we give them a small dose of Seroquel to knock the dopamine down. So we do this and we get back to balance, and hopefully you get the right dose of the drug, and it's keeping them right here, okay? But what inevitably happens is now all of a sudden we start doing this, we're blocking dopamine. Now we've got too little dopamine and too much acetylcholine. So now what do we see? We see the person who we're treating behaviors all of a sudden start to have a little bit of shaking. We see them start to drool because now they've got too much acetylcholine. All side effects because those two chemicals are out of balance. So the correct thing to do is when all of a sudden you get them back into balance, but then we start to see side effects coming out with the drooling and the shakes and all of those things. The correct thing is to say, hey, let's lower the dose of that drug that's blocking dopamine and bring them back up to here. Too often we say, let's add another drug. Let's give them a Cogentin, let's give them a Benadryl, something that blocks acetylcholine. So now you're doing this stuff day in and day out, and you can't, when really if we knock the dose back and get it right, we'll be doing fine, you know. I make my living selling drugs, but the last thing I want is on somebody on the wrong medication. I want everybody on the right amount of medication at the right dose, and to back them off is really the right thing to do with it. So that's why you see the side effects from the Seroquels and all of those things, is because of that balance with acetylcholine, okay? The next two chemicals, norepinephrine and serotonin, are responsible for depression, okay? If you don't have enough norepinephrine and you don't have enough serotonin, you'll be depressed. I mean, it's just a fact of what happens. Now, there's no real way to measure that other than watch symptoms. And like you said earlier, and I would agree 150%, is there was and still is to some extent a stigma attached to depression in this country. You know, somebody's depressed and we put them on a Prozac, you're weak. Come on, suck it up. You know, I mean, that's kind of what we say to people. I mean, that's what we say. But in reality, if they don't have enough of these chemicals and they get depressed, what serotonin, what Prozac and Paxil and all of those drugs, they build up serotonin. Same principle, they block serotonin from going back into here, so you get more serotonin out here. Same thing with mirtazapine or the other antidepressants, they help with norepinephrine and build those chemicals up. So what happens is we've got somebody who's been in a dark depression, and all of a sudden we put them on these drugs, and all of a sudden, you know, after a couple things is number one, it takes about 3 to 4 weeks for the drugs to work. Anytime we treat depression, it takes 3 to 4 weeks for those drugs to work. So all of a sudden, people who've been depressed for months start to feel better. And what do they say? Don't need that drug anymore. So all of a sudden, they get rid of it, and down they go. Okay? If that happens and the person slides back down, they really have a deficiency here. And they may need to be on Prozac for life. Who cares? It's no different than not having enough insulin. I mean, you know, if your pancreas, we don't look down on diabetics because they don't have enough chemical. But we do that with the
I'm on
others.
Zoloft.
What's up?
I'm on Zoloft. And I feel fine on my Zoloft.
It's true,
Right.
but it really isn't, and you may have to be on it for a long, long time.
Now, is there two of the same that are in the same category?
What you don't want to be on is like Zoloft and Prozac. They
I-
do exactly the same thing, but you could be on Zoloft and mirtazapine
'Cause
or
I take-
Remeron,
Remeron and trazodone.
not a problem.
Okay.
Not a problem, but, because they work on two different chemicals, okay? You don't want two drugs that work on the same chemical, okay? So again, the side effects with those drugs, you can see the anticholinergic effect, some reason with those, there's a balance there too, so you can see the dry mouth, you can see, you know, kids sometimes can get suicidal, so you gotta be really careful with these drugs in kids. But that's
Oh, that
depression,
makes sense.
okay?
It makes
It makes
sense why
sense.
she won't take that.
Yeah. And then the final chemical is GABA, and that's where our Depakote works. What it does is it blocks GABA, it takes down the pressure. Valium and lorazepam, everybody takes lorazepam too, terrible drug. But,
I do.
well, thanks, I'm glad, okay.
But I don't walk on the side of the wall.
We're not doing any therapy here, you know, no confessions needed, but lorazepam is good sporadically, you take it all
Right.
the time, not so good. I mean, you get tolerant to it really, really quick, so that's brain chemistry 101. Does it make sense? And how the drugs work and why you see what you see, so.
Kind of depressing.
A little bit. But, you know, again, here's the deal. There's always two questions with drugs. Number one is the benefit risk.
Right.
Okay, is it worth the benefit, like the gate
Yes.
for the behaviors? And it probably is.
Yes.
And the other thing is you got to get it to the right dose. Okay, if you have it to the right dose, you're not going to see the side effects and those kinds of things. But the key is to get it to the right. And I give this lecture to doctors sometimes. They don't really like me, but
Well,
That's
the
true.
thing is about that is
Mhm.
I've been in the medical field for 20 years and I don't have a lot of confidence in doctors.
well, there's good and
so-
bad and everything.
Yeah, I know,
Mhm.
but it's
Yeah,
a lot of
yeah.
Well, they don't
It's
have
like a
training in
gamble.
the pharmacology, really.
Well,
The
they have-
pharmacist doesn't
Yeah, they have a
study as
lot.
much
They
as-
do okay.
Yeah.
They do okay.
Yeah.
What you find, and I certainly don't want to put down docs, but
Right.
pharmacists today have huge training. I look at what my son's learned, and I'm going, "Are you kidding?" You know, and docs, what they typically do is they specialize, and as they specialize, they know those drugs they use inside and out usually pretty well. So they don't know the whole gambit like a pharmacist would know, but they know.
My doctor still has to look up in the pharmacology books sometimes to make
Wouldn't you
sure
rather
to
have him do
double-
that?
Right, that's what I'm saying, to double
I
check.
can't remember everything. You know, I can. It's,
Right,
yeah,
Double
absolutely.
check himself, yeah.
absolutely.
I have
But
a
what I
problem
mean
with
is
it.
a pharmacist, it's his day-to-day business,
Mhm.
you know, so he's
Yeah,
constantly
We
studying.
work, we work together. We work together. So, yeah, you bet. Come on through. Come on through.
Side effects sometimes.
Okay. So that takes us all the way through to the bottom of page 7 when we get to the gout drugs. So he goes, yeah, you know gout.
Yeah.
My mother
Last of the,
was just diagnosed with it.
there's a daughter here.
Your mail's downstairs.
My what?
Your mail from the house.
Why'd you bring it here?
Because I'm on my way to work.
Oh, okay.
Thanks. Work hard.
My mail's downstairs.
Is he good looking?
Yeah, if that's what she's talking about, can I leave now?
Anyway, one other, here's just a sort of aside on that. In the last category, antidepressants, on the third category, there's a drug there, imipramine, if you see that in there. Okay, in the next, okay. Here's you'll understand this now. We use that drug in kids to stop bedwetting.
Yes,
And
that's
it
why I
does,
knew
and
that
it does,
sounded
and it
familiar.
does a
Yes.
good job. How does it work? We're using
Yes,
it,
it
we're
works
using,
good.
yeah, it works really well. It's really an antidepressant, but it blocks acetylcholine in the bladder, and so it works really well
Give
with
that to
kids
the
too.
elderly people.
Can we double up on it for an elderly?
No,
No,
you've got
triple?
other things. You got
No.
Detrol and stuff for that.
Oh,
they don't
well,
work.
They don't. So
We'll
anyway,
just have
the next category is gout. Funny thing about gout is you know, we didn't see gout for a long time. Now all of a sudden there's more gout out there for some reason. But gout, what happens with gout is you get crystals of uric acid that form in the joints, and usually the first thing you see is the big toe, and it gets real red and real hot, and it's so painful that you can't even put a sheet on it.
Oh, yeah.
I mean, that's why you have bed cradles to hold the sheet above. It just is that painful.
Yeah.
So we treat, when somebody has a gout attack, we treat that with colchicine and some other things. Allopurinol we give to prevent those crystals from forming. But when an attack occurs, you may see an order that says this: colchicine, 0.6 milligrams, give every hour until pain goes away or diarrhea occurs. And I saw an order within the last month for that. That's exactly how they dose it. So hopefully the pain goes away before you deal with the diarrhea. But that's literally how they dose it. So if you see that, that's exactly normal, okay?
Is Grammy on that?
The next two categories are the antihistamine drugs. We use those for seasonal allergies. There's two kinds. There's sedating and non-sedating. The older drugs, the ones that knock you out, the Benadryl, the chlortrimeton, those all work really good, but you get all kinds of side effects with the anticholinergic effect of those
It's
drugs.
also put immunity to them.
Not really.
I
Yeah.
Benadryl
Yeah.
doesn't work.
Yeah,
Nothing works
it's
for
just-
me but Benadryl.
Yeah, I mean, it goes back and forth. The non-sedating drugs, the loratadine, Claritin, or the Allegra, you seen those? Here's one thing about those. Those drugs, in order to be effective, need to be given on a regular basis, okay? They don't work well taking them PRN, okay? So if you've got somebody who has an order for Claritin for seasonal allergies, hay fever, those kinds of things, you need to give it. It takes 3 to 7 days really to work well. So if you take it for a day, you won't get drowsy, but it won't work. Okay, so it takes a little bit of time for that to work. So if you're taking it during that time, you want to give it on a regular
How
basis.
come with Allegra it says not to drink fruit juice?
It's that interaction that
Oh,
may
okay.
cause the enzymes in the liver to get rid of it. So, the next bunch of categories are all antibiotics. Okay, they're all the biggest thing. And I'm not going to go class by class with antibiotics, but the biggest things with antibiotics versus allergies. Okay, be aware that you can get allergic reactions more frequently to antibiotics than any other drugs. Okay, and secondly, they kill good bacteria and bad bacteria. And what happens when you kill good bacteria? You get diarrhea. And so and we're seeing more and more when people get antibiotics, they're going on either a brewer's yeast or a probiotic or something to replenish that bacterial flora in the gut that helps to prevent that diarrhea from going on. Okay. The flu agents. Talk a little bit about the flu because it's flu season. Okay. Everybody have a flu shot? Don't tell me if you didn't. Okay. I didn't. Okay. But anyway, you really should get a flu shot because flu in the elderly it can be deadly. So you really, if you can protect our folks from infection, we want to do that too. But if you know how we make flu shots, or they determine a flu shot, we call it a crapshoot. Okay. What happens is every year, the Food and Drug Administration, or the CDC, Center for Disease Control, they look out, and there's about 250 different kinds of flu bugs. Okay, and they look at trends and they say, okay, what flus do we think are going to cause infections this year? And so they determine what 3 are the most relevant for infection, okay? And they put those 3 in a flu shot, and they're usually pretty good. But some years they just totally miss, and something else comes along, and the whole house gets sick anyway, okay? The key with flu and preventing flu is good hygiene. Wash your hands, wash your hands, wash your hands, okay? It's a quiz, okay? How long, if you come in contact, the way the flu works is that flu bacteria love to attach to mucous tissue. So if you inhale a flu bug that you haven't been inoculized against, it goes into your lungs, you get that crappy cough and everything from infecting your lungs. It goes into your intestine, I don't really have to tell you what happens when you get an intestinal flu, but you'll be puking and you'll have all of those other things. No, stand up
Go ahead,
straight, walk
Jimmy,
through.
go
No, just walk through.
Go ahead,
Yeah.
she's fine.
See ya.
Sorry.
That's okay. Okay. So what happens with the flu? If you looked at a flu bacteria, or not flu, a flu virus, okay, it's a circular thing and it's got little things sticking off it like this. Okay, one's pointed, one's flat, and it goes all the way around and it all sticks out like in all different angles. So it's like that, the knights used to carry and they used to whack people with. That's what. Yeah, exactly. Well, that's what the flu looks like. So what happens is when you inhale or come in contact with the flu, this little protein here, they both have names. Each one has, remember H1N1? One's an H protein, one's an N protein. With that one this was 1 and this was 1. So it's H1N1. This could be 1 and 2, H1N2, or whatever. So this first protein grabs a hold of the mucous membrane. What a flu shot does is it prevents that bug from attaching. It makes this protein irrelevant. It doesn't work. So when you get a flu shot, even though you come in contact with the virus, you won't get sick because it can't replicate once it gets inside of you. Okay, that's how it works. Okay, this little guy, okay, if it does attach to you and then starts dividing and make more flu bugs inside of you that causes you to get sick, this guy causes it to be able to be released from your tissue so it can go to another site and keep doing that and doing that and doing that. The drugs that we treat flu with, like Tamiflu and those drugs, even though this guy attached because you were stupid enough not to get a shot, it makes this guy not work. And so this guy doesn't work, and so what happens is it can attach to you, but it can't get off of that cell, so it can't go on and replicate, so you don't reach that critical volume. For somebody to take Tamiflu, they have to have it within 2 days of symptoms, because by the time 2 days have gone by, it's already done its damage, okay? So that's how it works, okay? If you wash your hands and keep everything and do all of this, I mean, it's amazing to me now they're teaching little kids in school how to sneeze right and all of those kinds of things. But viruses can stay on your hands literally only 3 minutes, okay? The acid on your hands and stuff will kill a virus in 3 minutes. But 3 minutes is more than enough time to do this, or to do it. On a hard surface like this, it will stay for 48 hours. So I heard a lecture, and the guy said, I don't get nervous if somebody's sneezing in the back of the plane when I'm on a plane. He said, I don't wear a mask on a plane. He said, I get nervous when I go to the airport and I put my hand down on a rail that somebody 2 days ago had sneezed on. So now every time I go through an airport, I'm kind of like this, not touching those rails. So just be aware, that's how the bug can hang
And how
around.
come sometimes when somebody gets a flu shot for the first time, 2 weeks later, they've got the flu?
It's coincidence.
So that happens a
It's
lot.
it's coincidence. It's really coincidence. It really
It's one
is.
of those things, huh?
It's
Does it matter if
coincidence.
it's a live virus or the inactive?
Well, the inactive is all the shots. The shots